Welcome to the Death Happens podcast, an insider's guide to dying. We're your insiders. I'm hospice nurse Penny.
And I'm Hallie, hospice social worker. Today we're going to be talking to M, that Spitfire nurse on social media. We're very excited to talk to her about oncology and palliative care. But first, we're going to talk about the choice to stop curative treatment and choose hospice. So Penny, I know you've been talking about this recently on the socials. Why don't you give us a little bit of a education piece here?
Yeah, so, it's a difficult decision. And sometimes doctors will tell the patient, I can't make a decision for you. I don't have a crystal ball. I think this treatment is still going to work. One of the things that has to be considered, I believe, when a person is deciding to stop that treatment and choose hospice is not only is the treatment going to be effective, is it going to prolong their life, is it going to cure their cancer, but how is that treatment impacting their quality of life? So I recently was talking to a friend whose husband has cancer, and he was having a lot of fatigue. That's one of his main symptoms from his treatment that he's getting, and his cancer is fatigue. And I said, is he on any steroids? Because we use steroids quite often in hospice. They work fantastic for fatigue. They work for bone pain. They work for brain tumors to kind of reduce brain tumor bulk and help with clear up confusion. They increase appetite. And so I was like, oh, is he on any steroids? That could really help. And she said, no, because the treatment that he's taking contraindicates with steroids. So he can't be on steroids. And I thought, so there comes a point where you have to decide, like, are you going to continue with this treatment that's really making him very sick, or stop the treatment, choose a different pathway? And so many people are reticent to choose that pathway of hospice because they're afraid they're going to die faster if they do it, which we've said many times before on this podcast.
The irony.
They're not. You can live longer, actually.
The opposite usually.
Yes. And that they're going to give up hope. And we ask them to reframe what hope looks like for them, to avoid the hospital, avoid the ER, be at home with your family and friends, do what you want to do, and have a better, improved quality of life. So I think, there's a lot of factors that play into people waiting so long to choose hospice. And unfortunately, when people wait so long to choose hospice, then they die right away, which sometimes the day they're admitted, they die. Then we see this idea that hospice is causing people to die faster, that they're disconnected from the fact that...
Yeah, it's really a complicated grief.
Yeah, yes, definitely is. And they're disconnected from the fact that just by virtue of going on to hospice, you have a terminal illness and you are dying. But it's so easy to see how people could draw that conclusion. The doctor sent my mom home on hospice. She died 2 days later. Hospice kills people. Hospice makes people die faster, whatever the rhetoric is. So we don't.
When you had some comments on your... Yeah, no, we don't. You had some comments on that post that you had recently that was talking about someone saying that that hospice killed their loved one. And there was a lot of clinicians on there saying, or family members saying, yeah, I've seen someone else being taken in and they have late stage dementia and they're getting cancer treatments or something like that. And that's a very different scenario. And of course, as hospice clinicians, we're heartbroken to hear that because that goes back to that quality of life piece. I get if you're younger and you have young kids and you want to maximize your life no matter what. Like your quality of life is living no matter what the side effects are. I get that decision.
Yeah.
When you have something that, like you're talking about, where at some point that decision is your side effects are not worth the treatment, then, and they're just not having the conversations because nobody wants to talk about it.
Right. Or you're 93 and you got cancer and now you want to do treatment for your cancer and you're 93. Like people don't understand it. I mean, there are some treatments that work. that don't cause a lot of side effects, and in that case, absolutely. My best friend since I was 22 years old has bladder cancer. The treatment for her was to do like radiation directly into the bladder. She's cancer cleared, terrific. But, somebody else has a type of cancer that's going to require all of these different chemo drugs ongoing, which is poison. You're trying to poison the cancer, and the side effects are often what end up killing the person. I know somebody that went through treatment for her colon cancer and fucked her heart up so bad that she was going to die from cardiac issues versus the cancer. Cancer's gone, but guess what? My heart's fucked now. I can't, I'm not going to live very long because I don't have any cardiac function anymore. There's just all of these things that have to be considered. And I want to acknowledge what a challenging decision that is. Because as I sit here, I couldn't tell you if I found out I had cancer, whether I would do treatment or not. It's easy for me to say, no, I'm not going to do fucking treatment if I have cancer, but it depends. What kind of cancer is it? What is the treatment? What is the realistic outcome? That's what you need to know. Realistically, like what are the statistics show? How many people survive this cancer with treatment? Like what are the side effects? But the other thing that blew my mind was my friend's husband is doing this chemo treatments. It's a pill that he takes. And I cannot remember I want to say $10,000 a pill or $10,000 a day. Just fucking outrageous. Like could not. I think it might have been could have been 1,000. Even if it's $1,000 a day, it's $30,000 a month. But I swear I thought she told me it was $10,000. Some just fucking outrageous amount. It's just disgusting. It's so, don't even get me started on healthcare and fucking big pharma and how much money is spent on, and some people, I'm not a conspiracy theorist at all. I don't buy into conspiracy theories, but when I hear people saying that the reason there's no cure for cancer is because big pharma is making too much money on the treatments, it's hard to not think that's true.
Well, hello. We're jumping into our intro here, and I see we're matching today with pink.
Oh, I didn't get the memo. Yeah.
Welcome, Em. We're so excited to get to talk to you.
Yay!
I'm so excited. Thank you. So excited to be here. Thanks for having me, guys.
The Spitfire
I would love to hear a little bit about yourself. Yes.
Yeah, for sure. So my name is Em. I go by the Spitfire nurse on Instagram. I am an oncology nurse, an palliative nurse. Actually, I've been an oncology nurse for about 6 years now, and a palliative care nurse for the past 2. So palliative nursing was actually not my first choice. I wanted to be a doctor, and then I worked in the emergency room and realized that I could not be a doctor. Like I was like, I need to be a nurse because nurses spend more time with patients. And I also realized I don't do well with authority, so I wouldn't drop out of that school. So nursing is a lot better for me, and I really enjoy, also, like when I was in nursing school, I was like, I cannot do oncology. It's like my no field. I was like, that's too tough. And then I ended up like trying it, and I fell in love with it. So it seems that this is a pattern for me. But I'm doing palliative care now, and I love palliative care. There's so much to do. There's a lot of education to do with patients and with providers, and I do that a lot at my job. I am based out of Houston. I work at MD Anderson here, and it's been great. So I've been planning on doing that. I'm gonna continue doing this. I was thinking about going to nursing graduate school, but I don't think I'm gonna do that. So here we are.
Well,
I think that's a great segue because we have talked before. Sorry, Penny. For the listeners out there, we're having a little bit of a delay, so we may speak over each other.
I heard the delay. I was just going to say you're on a good pathway to be a hospice nurse.
I love hospice, but I don't want to drive everywhere. So that is the biggest thing, because I live in Houston, and driving in Houston is a nightmare. So maybe inpatient. I thought about inpatient hospice. So that could be an option for me. But
Yeah, inpatient hospice is great. Driving is why I don't do patient care anymore. I was driving in Seattle and I hated it so much. I decided to take the virtual position in hospice quality because I was just over the driving. So I feel you on that. But inpatient hospice is amazing. It's an amazing experience. It's a really great place to work. So maybe that will be in your future. And if not, that's okay because people are needed in oncology and palliative as well. So I have a question. I wanted to know what got you started on social media and doing your education on social media.
So actually, it started during COVID. I think a lot of influencers, but I thought, it was really depressing for a lot of nurses. So I started doing like funny dance videos on my unit, and we would do like them weekly, just to raise the spirits of my coworkers and patients. Patients thought it was funny too. And then after COVID, I went into travel nursing, and during travel nursing, I was also making videos about travel nursing, but also like really like centered in oncology because I realized there was not a lot of education about oncology, nursing, and in general. And there's not a lot of oncology influencers out there as well. And in
Hmm.
nursing school, you get like, maybe a blurb on oncology nursing. You say, yeah, oncology nurses give chemo. That's it. And I was like, but there's so much more. And, it's fun because it's, nurses reach out to me and they're like, yeah, I'm interested in oncology nursing. I didn't get anything, anything in nursing school about it. Like, I'm really, can I ask you some questions about it? So it didn't start out, as a way to educate. It was more entertainment. And now I combine the two because I'm a terrible dancer, but it's a great way to get information across because people are like, wow, she's really bad, but like, this is entertaining and it's fun to watch. So, yeah, it's fun for me. It's a creative outlet for me. It's always been a creative outlet for me. And it's now turning, if I'm, get jobs here and there, it's great. But yeah, it's a fun way for me to explore my artistic side, which I don't really get to do in, my primary job.
So Hallie and I were talking
I would
about,
love for you to explain. I'm so sorry. Go for it, Penny. I'm just going to
it's,
wait until you tell me to
it's
go.
not, it's not your fault. I know, because then there's like dead silence if nobody says anything, and it's like, oh, this is terrible. I'm working from home, not working today. I need to be in the studio from now on. So, so Hallie and I were talking a little bit before about how difficult it is for people to make the transition from doing everything and treating their cancer to doing nothing. Well, we don't like to say doing nothing because we don't do nothing in hospice, but stopping the treatment and going into hospice. And we get a lot of patients who come to hospice just very, very late in the game, really end stage cancer, die quickly after they've come onto service. What's your experience with having those patients who are just going to fight until the bitter end? Now that you're in palliative, you probably see kind of a different side to the oncology treatment pathway. Tell us a little bit about that.
Yeah, so I've worked in the oncology field a lot, and I've only just recently transitioned to palliative care, but it's very interesting. You have a mixture of patients, and it's who, like you said, that transition is not made to the very, very end, and it's like when they do transition to hospice, it's like they go for like hours and then they pass, right? And then you have people who have a good kind of outlook on life, and they're like, I'm diagnosed with this disease that's terminal. I'm gonna do what I can, but when the time comes to make that transition, I'll be ready for it. And I have found, especially in my in palliative care, that it's the young patients who have children, that they're the ones who want to fight to the end. And I always tell my patients that it's like the doctors can give them prognoses, but they can never factor in willpower. And children are great reason to live, right? They want to live for as long as they can to be with their kids. But what I've found is that communication is key, right? So we try to get patients, and I always talk about it in my videos as well, consult into palliative care as early as possible, right? It doesn't have to be it shouldn't be at the end when hospital, we're trying to make that transition, right? Any patient who has cancer qualifies for palliative care. That's it. right? It can be at time of diagnosis, and it should be at time of diagnosis. We'll be here, we'll be there to make, to help them through their treatment, right? We're working with the oncologist, we're not working against them. We're just helping them, navigate their treatments. And then when it comes time to, like, I've gone through treatment to treatment, they know us and they know us well. We're able to have these conversations a little bit easier. Like, hey, like, you're on end line treatment. Like, what do you want to do? I would say 90% of the time, those patients are like, I think it's time for hospice. And that transition is so smooth. But that only happens if palliative care is involved early, if these conversations are happening early, not with just palliative with our team, but also the oncologist, with the family. And I always encourage my patients to have these conversations with your loved ones, because ultimately it's not them that's suffering, right? It's you. And as much as they want you to be around, like, you shouldn't put yourself through all this unnecessary suffering just to appease them. So it's a lot of communication, and that is so important.
No, Penny didn't say go. I'm not saying anything.
Well, if I say go, you won't even hear me forever. We're going to be cutting a lot.
If I start talking, then you'll start talking.
No, I was going to give you a chance.
All right.
Why don't we go? Let's try this. Let's alternate. You go, and then I'll go. Let's see how that works.
Okay. Well, you've already thrown my questions off, so now I have to wrap my head around what she just said. Just kidding, Em. So I love on one of your videos, you talked about trying to rename palliative care as supportive care, because palliative care can be a scary word. And we've done other interviews where we've talked about what palliative care is. I wonder if you might help us understand, especially from the oncology perspective, what does that practically look like when you're in working with an oncologist and you're working with palliative care as a patient and then as staff?
Sure. So, as a staff member, it's I am there to help manage symptoms, right? So it's like our role is, and the way I describe it to patients is, we are here to support you, which is why, supportive care is a great term for palliative care. But we're here to support you on your cancer journey, help you manage your treatment, your treatment related symptoms, your cancer related symptoms, so that you can focus on the important things, right? I always tell them, our job is to ultimately optimize your quality of life, so that you can just focus on the important things, yourself, your family, and your cancer journey. I go like, oh, that sounds good. And they're like, okay, cool. And they're like, yeah, we have all these symptoms that we can manage, pain being a big one for cancer patients. And, I just say it's a conversation. Like, we're just going to talk about your symptoms today. We're going to dive a little bit deeper, and as much as you want to share, you can. And, I tell patients the best part about our clinic is that, we focus on the mental health aspect, which oncologists just don't have the time to do. So practically, we're there to manage symptoms. I tell them if we can't help you, we'll refer you to a team that can. And for, a patient aspect, we're just another team here to help you. And your oncologist has brought you on for difficulty managing symptoms that, they may not be comfortable managing, or they've tried everything they can do, but we, in supportive care, we have a little bit more, or palliative care, a little bit more tricks up our sleeve, that the oncologist may not be aware of. So that's kind of what it looks like.
And just as a follow-up, I wonder for the primary care, because I feel like most people just then have their primary care and then an oncologist, which is already a little confusing on the patient side. Like, who do I go to for what? So palliative care, I imagine, even though it's an amazing supportive service that people deserve and need, then it gets more confusing about who do I go to for what. Is there an easy way for people to keep track of that?
So, yeah, we in palliative care, we always tell our patients, like, for this symptom, you have, for this issue, you have to go to your primary care. So what I say is, if it's a chronic issue that's not related to your cancer, then we send you to your primary care. So if it's like, I have diabetes, my blood pressure is high, that's something that we go to your primary care. Or if it's like, I have a UTI, like something like that, right? For us, if it's pain related, like, because pain is such a complex concept and requires a lot of, complex management, we always tell our patients we should be the only team that's managing that, right? We want to make changes to your medication. So and we need to know what changes are made so that way we can do it safely, right? If someone has a reaction to a medication, we need to know. So that's an oncologist. Like, we say, okay, if you're having like a acute side effect from your chemotherapy, like shortness of breath, or you have a rash, like that goes to the oncologist. So I hope, that was clear.
Yeah. So I follow a lot of people on social media, young people with cancer. And what I've seen is, like you say, the young ones especially don't want to kind of give up the fight. They want to continue the treatment as long as possible, especially if they have kids. There's one right now I've been following for quite a long time, couple years actually, breast cancer, metastatic, is everywhere in her body, in her brain now, all over, continues to keep getting treatment, 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 where I'm sure that there might be some oncologists who would say, let's just stop. This is, enough is enough. But she's got oncologists who will continue to treat her, and she's willing to suffer through the side effects for her kids. She's a very young woman. She's in her early 30s. And I imagine that at some point, probably soon, she's going to end up in the hospital and she's going to die there. And I've seen that happen with other young people on social media with cancer who ended up in the hospital and died in the hospital. Do you see a lot of cancer patients who are dying in the hospital, not on hospice?
So I work my setting now. I work in an outpatient setting, so I don't see a lot of patients in the hospital. But I have, in my past, when I worked inpatient, and yes, I do. Breast cancer is one of those diseases too. It's tough because a lot of breast cancer patients, it's caught early, and it's highly treatable, right? It has 98% 5-year survival, right? That's incredible for cancer. So I feel like a lot of breast oncologists, like they're really good ones, but there are also some that are just not comfortable having these conversations, right? Because the majority of their patients survive. So I do, young patients are a little bit more resilient too, and they're willing to put themselves through it. But I think they're less willing to have conversations with their families about this process as well, just because if they are young kids, they don't want to upset their kids. So it is unfortunate. I have seen quite a few breast cancer patients actually pass. I checked, I do obituary checks weekly in my clinic just to make sure that my, patients that we're keeping an eye on, if they passed or not. And yeah, it's honestly it's kind of weird in oncology. This is kind of the season where we see a lot of patients pass,
Mm-hmm.
and towards Christmas as well, just because people are not willing to change their code status because I need to make it to my last Christmas, right? I need to make it to my last Thanksgiving, right, with my family. So, but yeah, no, there are quite a few, actually a lot more young patients lately with end stage cancer that are just pushing their bodies to the absolute limits. And we see them. I do telemedicine visits, so I see them, and I see them, go from looking like me, healthy, to looking like literal corpses, and it breaks my heart. And we have what do you think? What do you want to do now? They're like, I have to keep going. I'm like look at yourself. And actually, my best friend, who is a pediatric palliative care nurse, that's her kind of specialty. And she always says, ask yourself, how do you want to be remembered? How do you want your kids to remember you? In the hospital, connected to all these tubes with tubes coming out of anywhere, of every orifice, or do you want to be remembered at home, surrounded by your loved ones? So that, asking patients that, I don't think it's rare for patients to be asked that. So when they do, they're like, that's it, they're like, I don't want to be in the hospital. No one wants to die in the hospital. So it's, again, communication, but it's also, it's making the patients shift their perspective and the way they think about, how they want to be seen and remembered.
Conversely, I've
Yeah, I
had
think that's
people
a
who
great
have
way to
said
think
to
about
me,
it.
This is the best podcast ever.
"Oh my God,
I'm glad you're having fun.
oh my God."
I'm having a great time.
So,
I promise it's not normally like this, but we are having fun
no,
with you.
yeah.
I know I'm having a blast.
I was going to say, conversely, I've had people who, and I've done videos about it, people who have commented on my videos that they had young kids and they wanted to die in the hospital because they didn't want to have their kids be with them when they're dying or see them when they're dying. And I have said, if you die in the hospital, your kids are unable to visit you as much as they want. They're not going to be able to be there and climb in bed with you in the middle of the night if they need a hug, and they're not going to see what's the reality of what's happening. And the not knowing can cause more fear than the knowing, like wondering about what mom or dad looks like, I think is something that can really create a lot of nightmares for little kids. It's better, I think, for them to be with their parents, their parent if they're dying, at home. I just think people are so, sometimes, not everybody, sounds like some are great about deciding to, go home on hospice, but sometimes they're just reticent to have their children see them, and they just don't want them to have them see them in the hospital, and so they choose to die in the hospital. And I really think we have, and that goes along with, like shifting the idea that death is this taboo thing and we should secret it away and no one should talk about it, and not acknowledge that it actually does happen to people.
Yeah, I mean, I think kids understand a lot more, even younger kids than we let on, right? They're very intuitive, and they know mommy and daddy is sick, right? It's like, okay, they're going to the hospital. So I think I completely agree. I think hiding that from their kids and not letting them see you in your final moments, that will create a lot of strife for the kids, but also for you, as the patient. Right. We always talk about like patients having unfinished business, right? And like their death is prolonged
Yes.
because they have unfinished business on earth. Right. So not being able to say goodbye, especially to your kids, like, I feel like that's just going to prolong your suffering, and make it like way worse for you in the end. So, there are ways, like, there are actually a lot of influencers out there that talk about how to talk to your kids about dying. Right. And I think like parents are so scared to do that for their kids, but I think it's the best possible thing to happen, because ultimately, like, you could die like tomorrow, right? You get hit by a car tomorrow, and your kid has to understand that, these things it can happen either suddenly or through a prolonged illness like cancer. So
Right, this is where I put my devil's advocate social work hat on. And I say, even though I think in my own personal life and in my family's circle that being at home would be the best possible option, and I totally agree about all the things about children and exposing them to it and naturalizing it and normalizing it, I know there are some cultures that if they are not doing everything they absolutely possible can, including being at the hospital until the end of life, then they have their own set of guilt and things about that. And there are some families I've worked with that it's not a necessarily cultural issue, but their plan is they'll be on hospice. Their plan is to call 911 and go to the hospital at the end. Like that's just the plan. No matter how much education there is, that's their decision. And, we'll honor it if they are making an informed decision. It's not the decision I would make, but it's the decision for them. So yeah, that's my 2 cents for social work since I'm surrounded by nurses here.
Yeah,
no, I think
I've
yes,
had
that's
those
complete.
patients. I've had those patients, definitely. All
Yeah.
and culturally too, like sometimes they're not going to even tell you that that's their plan, but because which cultures are going to be more likely to do that. And they kind of at the last minute they slip into the hospital and you're like, oh, okay, kind of should have known that was coming. But yeah, culture plays a big part in death and dying for sure. And of course we always honor that. So I appreciate the social work devil's advocate perspective.
Definitely.
I wonder, there's a video that you talked about on your socials about advice for new grads and people wanting to transition to oncology. I know Penny has mentioned before about hospice not necessarily being the best place to start a career if you're a new grad. And I definitely agree if it's not in a care center where you have support around you because you're out there by yourself figuring stuff out on the fly. What about oncology and palliative care? How does that feel for new grads?
So I went into oncology as a new grad. So I think oncology as a new grad is great because when I always say, there's different um, like oncology subspecialties. I happen to do medical oncology, which is like pretty much like med surg, but patients have cancer,
Mm.
right? So you're getting a lot of experience with different types of patients, with different scales and whatnot. I think the most difficult aspect of oncology is the death and dying aspect. Because as a new grad in nursing school, they talk about it, but you don't get access to it, right? It's like you may care for a patient one day and then they end up dying, but it's very rare for you to actually take care of a patient who is in that process while in school. So I always like when people ask me for advice for new grad oncology nurses, I always tell them, I was like, you need to prepare for this because especially the patients that are admitted, they're going to be admitted for either chemotherapy, for aggressive symptom management, or for end of life, or like that transition. And you got to be prepared for it. So, it's tough. And I always like, have a good self-care plan too, because it's a very emotional field. You're going to see cancer is one of those awful, awful diseases that can happen at any time for any reason, for no fault of your own, right? You can literally just wake up with cancer. So you're going to see patients from all walks of life, and some of them like really young and who you don't have a fighting chance, and they end up passing. So yeah, it's having that good emotional intelligence. With palliative care, I think it takes that a step further because palliative care and hospice are hand in hand. So you really do have to have a good empathy, good emotional intelligence, and just the ability to disconnect. My coping mechanism is when I clock in, I'm there, but when I clock out, I'm out. Like I do not
Yes.
think about work outside of work because my job is to. If I did that, like I would never be able, to do the job that I'm doing now, and I would not be able to be there for my patients in the emotional capacity that they need to be in. So
I call that emotional boundaries. You have to have good emotional boundaries. Good job, Hallie. I could see you like waiting for me to talk. I always said, same thing, like you cannot take it home with you. You can't. And I took it a step further by not going to funerals for my patients. So I always said, if I went to the funerals of my patients, that's all I would ever do. All my weekends would be full with funerals. And so for me, that was the emotional boundaries. And also just reminding myself that um, I'm a nurse. It's my job to take care of this person and their family. And this is not my person. This is that family's person. Like really reminding myself that I am there to do a job. It's not about me, it's about them.
Yeah, I think there's no way to teach that, especially in nursing school, because that's not your focus. But even in an emotional field like social work, that until you experience that, you have to learn from your other experienced colleagues about, we come into this field because we're caring people, because we give a shit and we want to provide this and we have this empathetic connection, but there has to be boundaries. And that's why it's so frustrating to see other folks on social media that completely not only blur, but jump over those lines. And then people that don't understand that that's not sustainable in so many ways. And it's not healthy for the patients, that they're seeing these stories and they'll think, oh, aren't they sweet? They were available for me 24 hours a day or whatever. And I'm like, oh my God, no, that's not how any of this works. Yes, I care about you
Yeah.
100%, 110% when I'm on the clock, but I got to put it down or I'm not sustainable for anyone else. And I know you've talked about
yeah,
that. Please talk to us about it.
yeah, it really bothers me when patients are like, oh yeah, my oncologist, I texted them on the weekend and like they responded. I was like, that's not healthy, right? I was like, I get like providers want to care for these patients, right? But if you're doing that, and how are you having time for, you have to go home and recuperate. You have to go home and rest. You have to go home and literally detach, right? This is a very, and like I said, it can be very depressing field. Everyone tells me that you're in oncology, you're like in a very depressing field. I'm like, it's sad, but it's also not all sad all the time, right? So, but you have to be able to completely and totally, like, my house is a safe space. Like, and I told myself that, like, even my husband knows that. He's like, he'll ask me, he's like, how was work? I say it's good. And he doesn't, continue, because he knows, like, I will vent on my drive home, but that's about it. And that is a very healthy coping mechanism for me. And I've been telling my doctors to do the same thing. I said, you have to stop. I was like, don't answer messages. I was like, just tell, like, the patients know that you're going to be there the next day. Like, if you start bleeding into, like, your home life, like, you shouldn't be taking your patients home with you, especially if you have families. I was like, that's going to create tension. And if you can't disconnect, you can make mistakes because you're just mulling over everything. So yeah, no, I completely agree with that. Like, and it's a serious problem, I think, with healthcare professionals, because, we are so dedicated to our patients, and we want to be available for them all the time. But yeah, that's my number one. It's just clock in, be there, clock out, you're out. Like,
And I don't think
you need
people
to have
really
a life outside.
I don't think people think about the consequences of, if you set that up as an expectation and then you're not available, then what? There are emergency services available to them, not us. That's how that works. That's why we have on-call hospice nurses and counselors, to cover when your core team's not there. You have to have faith in your colleagues, and you should instill that faith into your patients as well.
Absolutely.
Now, that's something we have tried to ingrain in our staff, like block your number when you're calling them so that they don't call your number back or they don't text you back. And I had a patient who, and I understand why they tried to reach me after hours, because our answering machine, our answering service was down that particular night before we switched over to the service we have now, CareXM, which is nurses all over the world who answer calls 24/7 if we don't pick up the call. We had an answering service before that, and my patient's husband was in crisis, and she called and couldn't reach anybody, and ended up calling my work phone, because she had seen, this was before we ever even thought about blocking our numbers. I would just tell people, never call me, don't call me, call the main hospice line, don't call me. And so in desperation, she called me. And in the morning, I woke up to a message that just broke my heart, because she was so upset. I can't reach anybody. I don't know what to do. I want to say there was something wrong with the computer, and she was able to reach, and they told her he wasn't on service or something like that. It was just some bizarre thing that was like,
oh man,
I was so pissed. I was like, oh my God, this guy's been my patient for months, and he ended up in the hospital, and he ended up dying in the hospital too. He became GIP and died in the hospital, and could have been avoided. We could have done continuous care at home and kept him at home, and it was just awful. But we keep seeing this problem, where our clinicians, just for some reason, they don't want to tell people, don't call my cell phone. Or when you're talking about boundaries and setting expectations, nurses or social workers or chaplains, usually it's nurses, who think that they are better equipped to help their person, and they're willing to take those calls after hours, and they want to be called after hours because they don't trust the night shift staff. So it was always telling my patients that you can trust the night shift. They're working. They're not in their pajamas. You're not going to wake anybody up. They are competent. They are trained. They are skilled, probably more skilled than your case managers, because they do lots of skills after hours. You can trust these people. So it was always just so annoying to me when there are people who think that, it's kind of it's arrogance, really, to say, call me, I know I'm off, but call me because I'm the only person that can help them. It's arrogance, and it's not healthy, and it's not sustainable.
I think too, it's part of the industry, the way the industry is going. My doctor always calls it she's tired of the customer service industry, right? It's like, and like, like this goes along with nursing schools calling patients clients. They're not clients, right? They're not like they're not paying, like, right? This is it's a service, and I'm not there to serve. Oh, well, technically not a service, but I'm not there. It's a hospital, not a hotel type situation, right? And that frustrates me too, because it's like if patient, setting expectations for the patients, if you're allowing them to contact you at like 1 a.m., right? Because some patients will send messages at 1 a.m., right? And you respond. What precedence do you set for that? Because if they go to another doctor, if they go to another service, they're going to expect the same thing. And that creates a lot of frustration. And it really, like, I work in an outpatient setting, and our lines go down at 4:30. So sometimes I'll stay later because I do like 10-hour shifts some weeks, but I will stop answering messages at 4:30, and I do that on purpose because I do not want to set my colleagues up for failure, right? It's like, okay, like she responded, like Nurse Emily responded at like 5, right? Like why aren't you guys getting back to me? And it's like, it creates a safety issue too, because some patients will message me like, I'm short of breath and have chest pain, and they always do that, like 4:45. Like I'm like, like you shouldn't be doing that. You know what I'm saying? But it does. I think it's a part of the industry of what the industry is becoming, which is also just that's a whole nother conversation. But you know what I'm saying? It's awful.
Yeah, for sure. Well, I want to take this a little bit more happy for a little while. Well, when I want to know what's maybe a surprising or a favorite experience or a fun experience that you've had in oncology, because like you said, a lot of people, and we get it all the time, oh, hospice, it's so sad. No, it's not all the time sad. I literally just had a young child with, I don't think I told you this, Penny, did I? I had a young child of a family come up to me and say, I can't poop. And you know what I need? Prune juice. Fun little things like that happen all the time. It's not always sad.
Speaking of poop, I mean, like, nurses love poop. I had this one patient, and like I always remember this story because it's so funny. It's so funny to me. I had this one patient that she only spoke Spanish, and the providers went in. This one was working inpatient. Providers went in, and they're like, "Oh, we need to give her like a smog enema, right?" And like they went in, and they're like, "Oh yeah, she's ready for it." I was like, "Oh, did you guys use a translator?" And they're like, "Oh, like no," because she said she understood. I was like, "She doesn't." But I went in, I was like, "Hey, I speak Spanish." So I told her, and I was like, I had to tell her, "So you're getting this treatment for your constipation." And she was like, "Oh, is it a pill?" I was like, "Oh no."
Oh,
I was
no.
like, "It goes up." I was like, "It's a tube that's going to go up your butt for a little bit." And she was like, "Okay." So, we got through that. She was okay with it. And then gave her the smog, and she was like, good. And I was like, "Please," I was like, "Tell me when when you're ready." And she just, would go through halfway through, and then like she's like, "Ah!" And she just gets up, hovers to the bathroom, right? And like I leave her in there for a little bit, right? And then I come out, I come back in a little bit to check on her. I was like, "How did it go?" And she goes, "Oh, so much poo poo. Oh my god!" Because I was like, it worked, obviously. Like, it's those kind of stories. It's like, okay, like you're having fun, right? Because it's like, okay, that is hilarious, and I will always remember that. That happened like my first year as a nurse. I was like, I am year 6, and I still remember it so vividly. So yeah, there are like little moments, like in oncology, it's like seeing patients ring the bell, or even when patients do make changes and being like, "Thank you for everything that thank you for communicating this with us. Thank you for everything you've done," or receiving cards from patients' families. That makes me feel good. That makes me, lets me know that I've done a good job. So,
and for
it's
folks
not
that
all
don't
depressing.
know what ringing the bell is.
So it's when patients are done with their treatment. So everyone thinks it's like, okay, when it's either remission or they're cancer-free. That's not the case. It's when they've completed that particular aspect of treatment. So radiation has one, and also, the infusion center has one. And when you've completed your psych, you ring that bell loud and proud.
Nice.
So yes, interesting about the bell, because a lot of people do think that is signifying that their cancer treatment was successful. And I did recently post a video. A woman whose child had cancer was going home on hospice to die. The treatment wasn't successful. And she had him ring the bell, and kind of the caption on her video was, "I'm a bad mom because I'm lying," or something. Like, she said something about, "I'm going to lie to my child. I'm actually taking him home to die." And so I posted a clip of that video with a follow-up saying, in the case of children who are dying, I think it's perfectly acceptable to allow them to think that their treatment was successful and that they're going to live, because why do you want to burden a child with knowing that they're going to die? Let them play with their Barbies and their race cars. If they ask questions, be honest with them, but otherwise, let them live out their happy little days. And boy, there's been a lot of comments on there from a lot of oncology nurses saying it means the treatment's done. And the mom probably knew that. And I think it was more a way to express what she was feeling about the situation. Like the bell was, it was in the periphery, really. It was really more about her not telling the child that the treatment wasn't successful. You know what I mean? It wasn't like the bell means it was successful, I'm letting him ring the bell and think that it was successful. It was just, I think, a way for her to convey that what she was doing and express maybe her own guilt over allowing her child to think that it was successful. It was an 11-year-old child. So anyway, yeah, there was a lot of feedback on there from many, many nurses saying when treatment is done, they get to ring the bell. It doesn't matter. But the interesting thing to me is it was pediatric nurses, mostly the comments that I've seen that said that. I did not realize that for adults, they get to ring the bell too when the treatment is done. I actually thought that the treatment was successful and that's why they rung the bell. And I never gave it any more thought than that. But as you say that, I realize how defeating it would be to go through the treatment, be told you're dying, it's not working, you got to go home on hospice. And by the way, just don't pay attention to the bell on your way out. You don't get to ring it. You know what I mean? So I'm glad that the bell is available for everybody who puts their self through, what is really can be a torturous treatment, to be able to ring the bell, even if it didn't work.
Yeah, absolutely. I commented on that video too. On your video. I was one of the oncology nurses that commented. But yeah, as you said, it is a celebration of the fact that you just completed something that, you're putting, I always tell my patients, you're putting your body through the ringer, right? You're putting toxins in your body, right? That's, I hate the word toxins, but that's what it is, right? They cause brutal side effects in some patients' cases. And, you're doing it for a reason. So, yes, you should be able to, ring the bell to mark that event, right? That you've gone through sometime, like multiple 8 cycles of hell. Like a lot of these chemo regimens freaking suck, right? It's like, I've had maybe like 5% of patients like say no side effects, but the majority of them are like, I would never do this again. And I was like, of course, like no one wants to do chemo, right? You have to do chemo, but you don't want to. So it is a nice way for them to mark, an event in their lives, in their cancer journey.
It seems like more and more I'm hearing about immunotherapy as opposed to traditional radiation and chemo. I'm just wondering if you might be able to speak to that a bit.
So immunotherapy is different from chemo, in terms of the side effect profile. So there's immunotherapy and there's targeted therapy. And it's a lot to do now with molecular profiling of the tumor itself. So what we call personalized medicine, precision medicine in cancer, which is really cool. Not every patient qualifies. Like you have to have this specific biomarker, so a genetic marker, either receptor or protein that these medications can target. But it's becoming standard practice now to when a patient comes in for diagnosis, if they haven't had molecular profiling done, they'll do it. They'll run and either it's a blood test or they'll do it on, when they do a biopsy, they can take some of that tissue from the tumor sample and send it off. And generally they have less side effects and patients are always asking, about it, but it really is, you have to qualify for it. And it's typically, and only in some cancers it's first line, but in most cancers you have to go through standard of care treatment to even qualify, like insurance wise, which we all love insurance, to receive these therapies. So yeah.
I did not know that. Thank you.
Yeah.
I know I have a couple more questions, but Penny, I'm looking at time, so I want to make sure you get in there before I do our kind of wrap up questions.
Go ahead.
Well, I wanted to know, just on the oncology side, as we're finishing up that conversation, is there anything that you want people to know about before they get a cancer or as they're getting into oncology treatment? Is there anything that patients should know that you feel like isn't really getting communicated?
I
know you talk a lot
honestly,
about screening, so that's an
yes,
important one.
thank you. Yeah, screening. Obviously nurses, people in healthcare make the worst patients, so it's kind of funny coming from me because I am really bad at going to the doctor, but guys need to get screened. It's really, really, really important. Cancer is extremely treatable, extremely survivable if caught early. So, when you qualify for these things, you need to do them. Like, it's not a question of like, should I? It's literally, you need to do it. If you have symptoms beforehand, talk to your doctor. It's usually, a matter of the fact of trying to get the insurance company to cover the screening test if it's not at the appropriate age. But that's super important. And if you see something and you notice something is wrong, like, get it checked out. Like, and do not be afraid to advocate yourself. Do not be afraid to go get a second opinion, because it really is like, I've seen a lot of patients be like, I went to so many different doctors and I knew something was wrong. And then by the time they're diagnosed, it was stage 4. And that is heartbreaking. A lot of times it happens with young women. So that is for like pre-cancer, but during cancer, it takes a village of people to manage one cancer diagnosis. So there's a lot of patients that don't like to tell family members that they have the disease. I strongly advise against that, because there's going to be times where you're going to need, the physical support, the practical support of getting to and from your appointments, taking someone, if you need to be taken to the ER, like, people need to know. So maybe whether it's a small group of people or, your whole family, but never keep that to yourself. That is something I think that most patients regret at the end, in my experience. So.
Well, we have a new question this season 2 called the coffin question. I know you've talked about asking other folks about their advance directives. Do you know what you want to have happen with your body when you die? And have you told your family?
I am 100%. I want to be cremated. Like, do not waste, like, my parents too, that are like, do not waste any money on any funeral. Like, but for me, I've been seeing this trend on TikTok and about having a living funeral, celebrating, the end of life when the patient's still, you're still alive. And I would love to do that, because I was like, I don't want anyone crying at my funeral. I want people laughing. I was like, I think that someone was like giving out people like tequila shots and everyone was having a good time. Like, that's what I want, right? Memory should be about celebration. I mean, funerals and like memorials should be about celebration of life. And I definitely I pride myself on being a very entertaining, like, upbeat, positive person. So that's what I want to see at the end of my life. But cremation for sure. Like, do not put me in the ground.
Excellent. I love it. Are there any topics we didn't get to that you wanted us to know about, or the people at large?
No, I think I forgot to mention this, but this really did change my perspective, and it's helped me be, since I've started in this oncology, is just that death is not, for these patients who are suffering, it's not a bad thing. My preceptor told me that at the beginning of when I was a student, on my oncology floor. And since then, it's really helped. It's for me, I'm like, okay, these patients are passing on, right? They're, they're free of their bodily struggles. And that has really helped me like process death better. Even for patients I was really close to, I'm like, okay, she's not suffering anymore. It's like, it's made it less sad for me. So that's really important. And I tell new grads that all the time as well.
Well, I know you said you're on Instagram. Is there anywhere else that people can find you if you want to be found?
Yeah, I'm on TikTok as well. It's that's Spitfire Nurse on Instagram, and then Jamie, ENJAYMIE on TikTok. Although my platform is definitely more pronounced on Instagram.
Wonderful. Well, thank you so much for being with us. It's just been a pleasure. I'm sorry about our technical difficulties, but you've been a champ through it all.
Thank you, ladies, so much. It's been a true pleasure. You guys are awesome. This has been the most fun podcast I've ever been on.
Well, that was a great interview with some really shitty technical problems. first time this season. We gotta have to have technical issues so people know that we are
I think it's required.
live. We're live. We're real. We're keeping it real, folks. We're keeping it real. I don't even know how much
Well,
editing
definitely
I'm gonna
not AI
bother.
because they wouldn't have those problems.
That's true. That is true. But that was a great conversation. I just think she is a Spitfire, and she suits her name really well. So the Spitfire nurse, really articulate, very articulate, really knows what she's talking about, and just adorable as heck. So cute.
Mm-hmm. And all the better to continue to have women in new generations, especially women of color, into the field of healthcare. That's so important. And being bilingual, speaking Spanish, hell yeah. Get in there, people.
Yeah, I didn't know that about her. She
I
should
love
be
it.
making some Spanish speaking educational videos too.
Yeah, heck yeah. Oh, all right. Well, next time, hopefully, the tech demons will be behaving as Kevin did, like a good boy.
Yeah, Kevin was a good boy.
And until next time, remember to live.
Because someday we'll all be dead.